Welcome to day 3 of Men's Health Week 2024. This is the third of a series of lunchtime men's health check-ins we're running this week. We had exercise on Monday. We had helping a mate doing it tough yesterday. Coming up on Friday, we've got the impact of alcohol and drugs on men's mental health. Tomorrow, we're talking about men's health check-ins. But today, hump day, Wednesday, we've got a talk which was our most popular topic last year, and we've got an excellent speaker to cover that topic with us. We are going to cover sleep today, and shortly I'll be introducing you to our speaker. But first, being in Melbourne, I would like to acknowledge traditional owners of the land where I'm meeting you from today, which is the lands of the Kulin Nation, and pay my respects to elders past, present, and emerging. So today's topic is sleep and its impact on health. How can we make sleep our friend? We have Dr. Alexander Sweetman with us, and he's the Senior Program Manager with the Australasian Sleep Association. Alex is coordinating a sleep health education and implementation program in Australian primary care. His main areas of expertise are in the non-drug management of insomnia and co-occurring insomnia and sleep apnea. He's got lots of knowledge, lots of information to share, and we look forward to hearing this talk, because sleep is something which we all have, and some of us more than others. I certainly know that I don't get as much sleep as I'd like during Men's Health Week, so I'm going to be paying particular attention to this talk. And I hand you over to the capable hands of Dr. Alexander Sweetman. Thanks, Alex.
Perfect. Thanks, Glenn and Kim for organising as well. Yeah, thank you so much for the invitation to present today, and lovely to see everyone attending. Thanks for joining and showing an interest in sleep health. So my name is Alex Sweetman. I'm, as Glenn said, a program manager with the Australasian Sleep Association. We're recipients of a similar Commonwealth grant that this Men's Health Week is funded through at the moment, or some of the outreach activities are funded through. And a lot of our work is also focused on primary care, education and implementation. Feel free to interrupt me throughout with questions. Otherwise, as Glenn said, feel free to use the chat function, and we can have a bit of a chat afterwards as well. So I'll share my screen, and you should all have my slides. Can I get a thumbs up from? Yep, perfect. All right, I'm going to mute my image so I don't have to look at myself. Perfect. All right, and before we begin, I would also like to acknowledge country. So the Australasian Sleep Association recognises and pays respect to the traditional owners of the lands where we live and work, both the Aboriginal and Torres Strait Islander peoples of Australia, and also the Maori as the Tangata Whenua people of the land of Aotearoa. So the Australasian Sleep Association is based in both Australia and New Zealand. I'm joining today from lands Order of the Kaurna Paramount people in the Adelaide Hills, and pay my respect to local elders past, present and emerging as well. So I'll orient you to what the Sleep Association is first before we dive into sleep health. So we're the peak scientific education and advocacy body for sleep health and sleep medicine in Australia and New Zealand. We represent about 1,000 clinicians, scientists and researchers who are really passionate and have a really diverse interest in all things sleep health and sleep medicine. So as Glenn mentioned, we all sleep, and it has associations with all facets of mental, physical health, quality of life, and so on. And there's researchers and clinicians throughout the country that are really interested in the diversity and whole breadth of sleep health and sleep medicine. And as I said, we were in 2021 the recipients of a Commonwealth grant. One of the main aims or focuses of our Commonwealth grant is to try and upskill and improve the management of sleep health and sleep disorders throughout primary care, with the hope that this helps everyday Australians in the community to access better evidence-based assessment, diagnostics and treatments for different sleep conditions and their sleep health when attending consultations with GPs, psychologists, nurses and other primary care clinicians. So why does sleep matter? Hopefully you don't need too much convincing. but I think it's an important slide to include. So we know that we need sleep to live. It hasn't been done in humans, but animals, some animals, when deprived of sleep, die. So we know that sleep is really vital and important for overall health and well-being. We think sleep is an essential biological need, just like food and water, and that it should be viewed as a core pillar of overall health alongside physical activity and nutrition. And anecdotally, we spend about 1/3 of our lives asleep. So it's important to know what makes healthy sleep and to protect and really value the importance of our sleep where we can. So for the next 30 to 40 minutes, I'll cover a little bit of background into sleep science. I'll talk about the concept of sleep health and population or preventive sleep health to paint a picture of what a healthy sleep pattern looks like, and then give a fairly rapid overview of different clinical sleep disorders, or some of the main clinical sleep disorders, what they are, what some of the symptoms are, what the different treatment options that are recommended might be, and who to turn to or where to go for more advice. A caveat, I'm not a clinician. My background is in research, education, and implementation. But if anyone's got any burning questions about your own sleep health, potential clinical sleep disorders, and so on, I've got access through the ASA to a really large network of sleep clinicians. And there's different sleep clinics or institutes in all of the major capital cities of Australia that I should be able to direct you to as well. So let's jump into sleep science first. Essentially knowing some basic facts and evidence-based information about sleep health. And why is this important? First, there's a lot of misinformation online, in the media, in the community, and so on about sleep. And sometimes this misinformation can exacerbate some of the concerns or some anxieties that people have around sleep awakenings and the consequences of sleep loss or interrupted sleep. So knowing the factual information can start to allay or reduce some of the anxiety that we sometimes experience about sleep when we don't think things are going as planned. On the flip side, knowing some of the information and evidence about sleep might indicate when it's appropriate to talk to a healthcare provider if we don't think things are going quite as they should be with our sleep. Again, it can protect us against some of the fear-mongering headlines that we see in the media that can exacerbate fears. And there's a lot of recommendations and information online. This isn't always evidence-based information, and it can help to understand some of the evidence-based treatments and aids that are more likely to help sleep versus those that aren't based in scientific evidence. So let's dive into some of the ways that we measure sleep, how it looks, and some of the population sleep metrics. So I'll be talking about lots of different facets and domains of sleep over the next half hour. One of the really important caveats is that there's a lot of individual variability in a lot of the different stuff that I'll be talking about. So sleep duration, the duration of sleep, or how many hours of sleep we have each night. While most people need about 7 to 8 or 9 hours sleep per night or per 24-hour period to feel well and function well during the day, some people need slightly less sleep, so 6 to 7 hours. Some people only need 6 to 7 hours to feel well and function well during the day, and some people might need slightly more, 9 to 10 hours. So individual variability around these precise estimates, not only in the duration of sleep, but also timing of sleep, the impact of sleep on how we're feeling and how we're functioning during the day and so on. So it's an important thing to keep in mind that your sleep and sleep needs won't necessarily be exactly the same as all of your family members, friends, colleagues, and so on, and that's completely okay. This is a graphic from the National Sleep Foundation in the United States, showing the recommended hours of sleep that we should achieve or obtain per 24-hour period. So this is the hours of sleep on the vertical axis over here, and then throughout the lifespan, so from newborn and different age brackets to older adulthood. And then the numbers, the dark blue indicates the recommended hours of sleep per 24-hour period, and the turquoise indicates may be appropriate, and then outside these bounds is probably not recommended. And then it's got the numbers indicated for each age bracket here as well. So we can see that as well as individual variability, so each individual is slightly different, we also know that sleep need and sleep parameters change throughout the lifespan as well. So the most obvious change here is a slight reduction in our sleep duration or sleep need from being a newborn through to about the teenage or young adult years. And then it plateaus or stabilizes from young adulthood to older adulthood. So a slight reduction during earlier age and then plateaus to about 7 to 9 or 7 to 8 hours of sleep per 24-hour period throughout adulthood. What's one of the take homes here, if we're an adult or older adult, we shouldn't necessarily expect to be sleeping exactly the same as we did when we were at school or in our teenage years. So it's completely normal for that sleep duration, sleep need to change throughout the lifespan. We also have a lot of different ways of measuring sleep and assessing sleep. And sometimes this can be a little bit complex and confusing to navigate all of this. So I'll give a brief overview of some of the different measurement tools and techniques that might be used. Some of you might have experienced some of these different measurement tools or know someone that has. On the top left, this is an overnight sleep study, or polysomnography, this is called as well. This person has a lot of different electrodes attached in the hairline, forehead, next to the eyes, face, and some bands on the chest, legs, and finger, and so on. These overnight sleep studies can be performed either in a sleep laboratory, sometimes in a hospital or a sleep clinic, and they can also be set up in a sleep lab, and then the person can actually take all of the equipment home to their home environment, sleep in their own bed wearing the equipment, and then bring it back the next day or a couple of days later to have the equipment downloaded, scored, and analysed. Broadly, a couple of electrodes will be in the hairline here, as well as these ones on the forehead, which are measuring brain waves. The two next to the eyes are measuring eye movements. There's a couple on the chin measuring muscle tension. These leads going under the nose are measuring breathing during sleep, so breathing through both the nose and mouth during sleep. A finger oximeter to measure blood oxygen saturation. Bands around the chest and abdomen to measure respiratory effort, or how much the body is trying or attempting to breathe, as well as electrodes on the legs as well, likely to measure leg movements and so on. So very much wired for sound and not the most comfortable way to measure sleep. It's a little bit paradoxical that people wear so many of these wires and different devices and then are expected to sleep. I worked for 10 years or so as a sleep technician in different sleep laboratories. And of the probably thousands of patients that we monitored, there were a very, very small handful that weren't able to sleep at all wearing all of this equipment. So sleep is quite robust and people can sleep in odd and strange situations as well. On the left-hand side are some of the different traces that we collect. So each row is a different trace, and this is showing changes over about a 30-second period. So we have different brain waves in black, eye movements in blue. Red is the muscle tension measured with the electrodes on the chin. Heart rate, so this person will be wearing ECG dots as well as some of the different respiratory measures, so how much they're attempting to breathe, how much they're breathing through their mouth and nose here, and oxygen saturation. So really helpful for assessing and diagnosing some sleep disorders, but not always indicated. Other sleep disorders, like insomnia is one of them, can be assessed all through self-report measures, like a questionnaire. So no overnight sleep study is actually required to diagnose insomnia per se. It's done mostly via questionnaires, clinical interview, and then what we can see here in this middle pane is a sleep-wake diary. So this sleep diary at the top, it's a 2-week sleep diary, allowing someone to self-report when they were in bed, when they were out of bed, when they were awake, and when they were asleep. Each morning, so when they get out of bed, they think back on the night before and self-report the times that they were in bed and asleep and so on, each morning for about a week and a half here. And pretty quickly, when this is filled out each morning when getting out of bed, we start to develop a really comprehensive picture of what a person's sleep and wake parameters look like from night to night. On the phone, this is also a sleep diary being completed on a phone, and online surveys probably though So similar information, just a different modality. So it depends on people's preferences. We know smartwatches, a lot of smartwatches available and in use now, a lot of them measuring sleep or different sleep parameters as well. The validity or how accurate they are differ from device to device. Really broadly though, they're quite good at detecting when we're asleep and when we're awake throughout the night, or how much sleep we had throughout the night, and also when, or the times that we're in bed and out of bed. They're not as good at detecting different stages of sleep. So some claim to detect light sleep, deep sleep, REM sleep, and so on. Those are generally not as accurate when we compare them to the full polysomnography, which we would expect because there's a lot more measures that are being used in this one. So good for total sleep duration, not as good for some of the other more precise metrics like sleep stages, respiratory events, and so on. Not surprising because it's a limited number of channels or traces that they're using to measure. And finally, falling into a similar category as the wearables, this is the nearables as well now. This is a mat that can slip under the mattress and is able to use different traces to create a proxy of our sleep and wake patterns, how long we're asleep, what stages of sleep we're in, respiratory events, and so on. Again, probably not as accurate as polysomnography, but the benefit is that we can measure sleep over multiple nights with this one. Obviously much less invasive, and we can get a more comprehensive picture of how someone's sleep and wake patterns are changing over multiple nights, rather than just a once-off recording. That gives you a bit of an idea of the landscape of some of the evidence-based measures that are used to assess sleep health in the sleep medicine field. We'll dive a little bit deeper into different stages of sleep. So after we fall asleep, our brains and bodies progress through different stages of sleep throughout the night. And it can be handy to have a bit of an understanding of what these are and what these look like. So in the last column here, we have our brainwave activity. When we're awake, our brains show this pattern of really high frequency and low amplitude activity. High frequency means the waves are clustered really close together. Low amplitude means that they don't go to very high or low peaks or troughs here. When someone's awake, obviously alert, immediately responsive, and we know that we're awake right now. And then when we cross into stage 1 sleep, so this is our lightest stage of sleep, the brainwaves slightly lower amplitude, so the peaks and troughs are a bit shorter or smaller. Slower frequency activity as well, so the waves are a little bit more spread out when we progress from wake to stage 1 sleep. During stage 1 sleep, we still have drifting thoughts and mentation. It's quite easy to wake up or wake someone else up out of stage 1 sleep. Because we're still having drifting thoughts during stage 1 sleep, we might wake up, remember that we were having a thought about the shopping list or what to do the next day, and we might infer this to think that we were actually already awake, but this isn't always the case. So we do still experience drifting thoughts during this lightest stage of sleep. The next stage 2 sleep, our moderate stage of sleep, really distinct patterns of brain activity. So these are called sleep spindles and K complexes. And then we progress to our deepest stage of sleep, stage 3 sleep, which is sometimes referred to as the most restorative stage of sleep. However, all stages of sleep are important in different ways. Sometimes referred to as deep sleep or slow wave sleep, because the brainwaves have this really high amplitude and low frequency pattern like this. Oops. And it looks a bit like slow waves out in the ocean, deep rolling waves. So hardest to wake up from stage 3 sleep. And if we do wake up out of stage 3 sleep, we'll probably know that we were previously awake. We'll probably feel really groggy and tired. It will be quite obvious that we were previously asleep. And finally, rapid eye movement sleep, or REM sleep, where most of our vivid dreams occur, really low pattern of muscle activity. The brain waves during REM sleep look really similar to stage 1 sleep here, so a low amplitude, fairly high frequency pattern of activity. Again, it can be pretty obvious if we wake up out of REM sleep and we were having vivid and unrealistic dreams. It can be quite obvious that we were previously asleep. So what does all of this look like when we put it together and look at a person's what our sleep looks like throughout the night? So we'll start with a healthy younger adult, and then I'll show you what a healthy older adult sleeping pattern looks like as well. So on the vertical axis here, we've got the different stages of sleep that we just talked about. So when we're awake, and then we've put stage 1 sleep and REM sleep together here, just because the pattern of brain activity was quite similar. And then going to moderate stage 2, 3 sleep and our deepest stage of sleep, stage 3 sleep. And then we'll have a look at what this looks like during each hour of sleep. So this person, from the hour that they got into bed, each hour throughout the sleep period until they got out of bed the next morning after 8 hours of sleep. So a lot of people think that after we fall asleep, we enter this deep valley of unconsciousness. We progress pretty quickly down to deep stage 3 sleep and stay there through most of the night before gradually progressing back up through the sleep stages to wakefulness. But in fact, the sleep architecture or sleep structure throughout the night looks a little bit more like this. More like a roller coaster where we go up and down through different sleep stages throughout the night. So each of these different dips is called a sleep cycle. So that's one sleep cycle to here. We experience somewhere between 4 to 6 sleep cycles throughout the night, and each sleep cycle lasts for about 90 minutes or so. So we can put some text descriptors on these as well, how we're progressing up and down through the different sleep cycles throughout the night. Another couple of important things that can be helpful to talk about: most of our deep stage 3 sleep is occurring during these first 2 to 3 sleep cycles here. In some people that are not sleeping as much or are becoming quite anxious about missing out on sleep, it can be helpful to talk about this. So to reiterate that even if they're only sleeping for 6.5 hours each night, that they're probably still acquiring most of their deep restorative sleep during those first 2 to 3 sleep cycles. We experience most deep sleep during the first half of the sleep period. Inversely, we experience more light sleep and REM sleep during the second half of the sleep period. Another thing that can be really helpful to talk about is these brief awakenings from sleep. Everyone experiences brief awakenings from sleep every single night. These are a completely normal occurrence. Some people remember them, some people don't remember them. In some cases, people might think that they're waking up during the night, and if their bed partner or colleagues or friends don't experience this or don't remember this, they might think that there's something wrong with their sleep or that it's a sign of ill health. So it can be good to reiterate that these brief awakenings from sleep are a completely normal part of healthy sleep architecture. Ideally, we want them to be brief awakenings, limited to sort of less than 5-10 minutes. And similarly, ideally, we want to be falling asleep in less than 20 to 30 minutes or so. So this is the healthy sleep pattern of a younger adult. How does this change with age? So this is the sleep pattern of a healthy older adult. So some of the main things to take notice of: still different sleep cycles. Most of our deep sleep still occurring in the first half of the sleep period. However, overall, slightly less deep sleep and slightly more light sleep and REM sleep with age. So the proportion of the time spent in different sleep stages changes with age. Again, completely normal. Slightly more frequent awakenings occurring with age, maybe related to more light sleep and more REM sleep as we grow older as well. Again, these brief awakenings are a completely normal part of our sleep architecture with age. Healthy older adults can feel well and function just as well during the day as healthy younger adults, despite this. Another couple of things that can be helpful to talk about, some of the sleep science. There's two main factors that control the timing and the quality of our sleep. The first one is sleep pressure. So sleep is a biological need, just like food and water. The longer we go without food, the hungrier we become. The longer we go without water, the thirstier we become. And similarly, the longer we go without sleep, the sleepier we become. And that's what this graph is showing. So on the vertical axis, we have our level of sleep pressure or sleep need or how sleepy we're feeling at different times of the day. So higher sleep pressure at the top and lower sleep pressure at the bottom. And then we've plotted this over the 24-hour period from 7 a.m., which is the time that this person woke up and got out of bed, through to 11 p.m. at night, their bedtime, through to 7 a.m. the next morning, so a 24-hour period. So what happens to our sleep pressure during this time? From the moment we wake up and for every hour that we're awake throughout the day, our sleep pressure is gradually increasing until it's at its highest point here at the time that we get into bed and go to sleep at night. And it's partly this higher sleep pressure in the evening that actually helps us fall asleep quicker and return to sleep more rapidly if we do wake up during the night. So what happens after we fall asleep? Our sleep pressure is reduced at first, quite rapidly for the first half of the night, and then more gradually for the second half of the night, until it's back to this baseline level at 7 a.m. when we get out of bed the next morning. And this shark fin shape is repeated each day. So some different behaviours can impact our level of sleep pressure throughout the day and evening, and then therefore can have an impact on how we're sleeping that night. So things like a really long afternoon nap. This person's taken a 1.5 to 2 hour nap in the afternoon, immediate reduction in their sleep pressure during this nap time. They then wake up from their nap with lower sleep pressure that gradually starts to build again after they wake up. But at 11 p.m, their sleep pressure is lower than what it would have normally been, and that might mean that they take a little longer to fall asleep that subsequent night. Or if they wake up during the night, they might spend slightly more time awake. Brief naps are completely okay, so 10 to 15-minute naps, completely okay during the day. Probably best avoided in the late evening. It would be better to just wait until bedtime rather than take a brief nap. But brief naps earlier in the day, afternoon and so on are completely okay. It's the longer naps that can start to have an effect on our sleep pressure. Similarly, if we go to bed really early in the evening, say 9 o'clock or so, our sleep pressure won't have increased as much, and it might be harder to fall asleep this time. So this is stuff like getting into bed early before a red-eye flight. Sometimes we won't fall asleep immediately until our normal bedtime or sleep onset time that can delay that sleep onset period. The other process that can control the timing and the quality of our sleep is our body clock or our biological clock. We experience change in our levels of alertness and sleepiness over the 24-hour period, changes in lots of different biological rhythms. Our level of sleepiness is one of them. I won't go into detail, but basically if we try and fall asleep at a time that's not convenient or consistent with our body clock, it can be harder to fall asleep. And similarly, if we try and sleep in when our body clock is signaling that we should be waking up, it can be harder to sleep in or stay asleep. One way of judging this is how sleepy we feel. So in the evening, ideally we want to start to feel really sleepy, like our eyelids are heavy, and that if we put our head down onto the pillow, we could fall asleep. That's indicating that our body clock is signaling that it's a conducive time to get into bed and fall asleep. Again, everyone's body clock is slightly different, the timing, which gets back to that individual variability. So for many decades, the field of sleep medicine and sleep research has really focused a lot on clinical sleep disorders, which are most severe end of what happens when sleep health is not going well. But over the last decade or so, more and more it's been recognised that sleep health is important for everyone, and that we should approach sleep health from a preventive health perspective as well, and look at what positive or healthy sleep entails, it looks like. So sleep health for the field is a relatively new concept. It's a multi-dimensional concept, so it's made up of different components, and it's helpful to think about sleep health from a preventive or population sleep health perspective. So sleep matters for everyone, and we should understand the importance of sleep and promote the importance of sleep for everyone, not just those with a clinical sleep disorder. So we came up about 12 months ago, we came up with this working definition of sleep health. If you're not a text-based person, I've got an image on the next slide. I'm much more visual in the way that I learn. But we define it with different domains. So an optimal or healthy sleeping pattern is one that is of sufficient duration and quality for a person to feel well rested and restored to function well during the day, during wake hours, is relatively stable from night to night, aligned with the person's internal body clock, consistent with how much sleep they need and the timing of their sleep, and not occurring in the presence of an untreated clinical sleep disorder. So I've underlined 6 different components here, which are these 6 components that we think make up healthy sleep patterns. So it's not just about duration or the average number of hours of sleep per night, which was that National Sleep Foundation figure that showed decreasing sleep need during the lifespan. It's also about quality. So what happens, or what does our sleep look like during the time we are asleep? Any long awakenings or sleep disturbance? Regularity is important. So how regular is our sleep and wake timing from night to night? Is it relatively consistent, or does it change a lot? Generally, we should be aiming for a relatively stable sleep and wake pattern from night to night. That's related to the timing of our sleep pattern as well. So that's whether some people are more early sleepers, so they go to bed earlier in the evening, wake up maybe earlier hours of the morning, compared to the stereotypical teenage sleep pattern where it's more delayed, so going to bed later at night and sleeping in until mid-morning or early afternoon. Everyone's sleep timing is slightly different. The daytime impact of our sleep, so whether we feel well rested, restored and alert during the day. And this is recognizing that these other parameters have a lot of individual variability. So different people need different duration, quality, and so on. And it's really about how well we feel rested and how we can function during the day. And finally, no untreated clinical sleep disorder. So we think if there is a clinical sleep disorder like insomnia, sleep apnea, and so on, that it's important to treat these to have a healthy sleep pattern. So what are some pragmatic recommendations? I've included a handful here, but the Sleep Health Foundation is a consumer-facing advocacy body in Australia, produce a lot of evidence-based online resources and fact sheets for people not only with clinical sleep disorders, but anyone in the population who's interested in learning more about sleep. Lots of freely available online fact sheets on clinical sleep disorders and pretty much any facet of sleep that you can imagine. A not-for-profit, non-government organisation, the sister organisation to the Australasian Sleep Association. So lots more information on their website for anyone that's interested in digging further. But some basic recommendations, just to know about the nature and structure of sleep. So some of the things that we've just spoken about, that brief awakenings from sleep occurring a couple of times a night can be completely normal. The structure of sleep, so most of our deep sleep occurring in the first half of the sleep period, and more light sleep and awakenings occurring in the second half of the sleep period. Changes in sleep with age, again, completely normal and not necessarily a sign of ill health. And also that there's a lot of variability from person to person. So we shouldn't expect our sleep to look exactly like our friends and family and so on. What are some of the pragmatic recommendations to protect our sleep or ensure we have the best sleep that we can? One is to care generally about our sleep and seek out further evidence-based information. But there's some changes like limiting light and noise in the bedroom throughout the night and maintaining a cool and comfortable sleep environment. So trying to make the bed, pardon me, or bedroom environment as comfortable and as conducive as we can for sleep. One of the easiest things that we can do to start improving or protecting our sleep is to get out of bed at a fairly consistent time each morning. For most people in the population, doesn't apply to everyone. Some people have body clock sleep-wake disorders or circadian rhythm disorders where they need some caveat here. But for most people, getting out of bed at a consistent time each morning, getting some exposure to natural light, so the sun shine, and starting to increase our sleep pressure from the moment we get out of bed in the morning. This will all help to resync our body clock with the daylight cycle and also help to help build that sleep pressure curve, that shark fin curve that will help us fall asleep on the subsequent evening or return back to sleep if we wake up throughout the night. We know that caffeine is a stimulant, and this doubles for other different types of stimulants as well that we consume, to limit caffeine overall and try to avoid caffeine after about 2 p.m. because it has a really long half-life and it can stay in our system for many hours. We want to be removed from our system by the time we get into bed when we're ready for sleep in the evening. Obviously coffee, but caffeine in lots of different things, some energy drinks, caffeinated teas and so on. I'm generally avoiding heavy meals or excessive liquid consumption before bed, probably in the 2 hours leading up to bed. We don't want to be digesting food throughout the night. We don't want to be waking up to go to the toilet many, many times throughout the night because we've drunk 2 litres of water right before bed. And finally, using the bed only for sleep and intimacy. So avoid any other wake activities in bed, and ideally do those activities in a different room. So what are those activities? Things like using our mobile phone, social media, doing work, arguing or talking to our loved ones, eating, playing with pets. Pretty much any awake activity is best done in another room or at least out of bed. We want to use the bed only for sleep and intimacy. That's to help teach our brains and our bodies that the bed is a place for sleep rather than a place for being awake, doing work, using the mobile phone and so on. Ideally, we want the bed to be a cue or a trigger for our brains to know that right now it's a time for sleep, relaxation and rest, rather than the bed becoming a cue for being more alert, anxious or worried. So using the bed just for sleep and intimacy. Alrighty, sorry. So I'll touch lightly on some clinical sleep disorders here, and I'll caveat again, I'm not a clinician, but there's many, many clinicians, sleep physicians, psychologists, and so on throughout Australia that will be able to help and provide more assessment, diagnostic, and treatment recommendations to you. So we'll cover insomnia, obstructive sleep apnea, and then touch on some other clinical sleep disorders, what some of the symptoms or presenting features of these conditions are, and some of the treatments that might be recommended. So let's start with insomnia. Insomnia is the most prevalent sleep disorder in Australia. It's diagnosed according to self-report symptoms. So no overnight sleep study is actually required for a diagnosis of insomnia per se. Although an overnight sleep study might be recommended if a comorbid or co-occurring sleep disorder is suspected. Insomnia is broadly diagnosed according to sleep symptoms and daytime symptoms. The sleep symptoms can include difficulties falling asleep at the start of the night, really frequent or more often long awakenings throughout the middle of the night, or early morning awakenings and difficulties returning to sleep again. Sometimes these 3 different types of sleep symptoms, or the 3 clouds, are broken into early, middle, and late insomnia symptoms just based on the time of night that they occur. Diagnostic criteria for insomnia indicate that they should occur on 3 or more nights per week. And then they should also be associated with daytime function impairments, or pretty much any symptoms during the day that someone might experience in association with these sleep symptoms. So I think we can all empathise and recognise how we can feel pretty lousy or pretty crap after a night of poor quality sleep, or reduced sleep duration, feelings of fatigue, sleepiness, poor mood, concentration or memory difficulties. And some people report reduced workplace productivity and social functioning. I think we can all empathise with a night of poor sleep and how it can impact our daytime function. And then if we extrapolate this to people with insomnia who experience sleep difficulties most nights of the week for many months or years, it's easy to imagine how insomnia can start to have a really profound and significant effect on someone's daytime feelings, functioning, and quality of life. How common is it? Very common. About 30 to 50% of Australian adults report short-term insomnia symptoms. So at any given time, up to 50% of the population report short-term insomnia symptoms, and about 10 to 15% of Australian adults fulfill formal, quite conservative diagnostic criteria for chronic or long-term insomnia. So it's defined as chronic if it occurs for 3 months or more. So chances are 1 in 10 people that you know or see or meet day to day in Australia likely has a chronic insomnia condition. Previously, insomnia, there were sort of stereotypes, and it was seen as a disorder mainly affecting females, mainly middle-aged to older adults, and those with an anxious personality or predisposition for anxiety. Now it's much more recognised that insomnia impacts everyone, Australians of all ages, genders, and backgrounds. Lots and lots of different causes for short-term insomnia symptoms in our society. So there's lots and lots of different mental and physical stresses that we experience day to day that can cause short-term insomnia symptoms. And anyone can start to develop different cognitive, psychological, and physiological processes that allow these insomnia symptoms to persist over time or become a longer-term condition. So more recently, it's been recognised that insomnia can occur in anyone. We should be relying on these stereotypes that can lead to some of the referral or diagnostic biases. What are some of the consequences of insomnia? So we've talked about fatigue, poor mood, some of those daytime impacts. Over time, reducing overall quality of life. People with insomnia talk about reduced social function, reduced workplace productivity, higher need to access health resources, so taking time off work to go to GP appointments and so on. And one of the main or most common consequences of long-term insomnia is developing poor mental health. Easy to understand if you think just one night of poor sleep can start to impact how we feel and function during the day. When that's happening night after night for a long time, it's easy to empathise that long-term insomnia symptoms can increase someone's risk of developing depression, anxiety, and so on. And some epidemiological research indicating some associations with hypertension and cardiovascular health as well. This isn't to scare people. Thankfully, there's a really effective treatment for chronic insomnia. It's called cognitive behaviour therapy for insomnia, or CBT with a little I at the end. There's CBT for lots of different conditions, CBT for depression, CBT for anxiety, and there's also a CBTI specifically for insomnia. It's recommended as the first-line treatment or the first treatment that people with chronic insomnia should receive. And this is because there's hundreds and hundreds of scientific studies and over 40 meta-analyses, which is when researchers compile all of the different scientific studies into one big body of evidence. Lots and lots of scientific research showing that CBTI improves insomnia, daytime function, quality of life, depression, reduces someone's dependence on sedative or hypnotic medicines, so sleeping pills, and it's cost effective over time compared to continued sleeping pill use or pharmacotherapy. The really good thing is that this non-drug treatment leads to all of these positive effects, which are sustained long after time. So even after a sort of 4 to 8 session CBTI program, improvements in all of these symptoms are sustained for many months and years into the future. And why is this? This is because CBTI aims to identify, target, and treat all of the underlying factors that maintain chronic or long-term insomnia. So we can think of insomnia a bit like an iceberg, where inadequate sleep and some of the daytime factors, so those sleep and daytime symptoms, the main diagnostic symptoms are just the tip of the iceberg, or the bit above the surface, whereas actually it's maintained by a whole range of psychological and behavioural patterns and factors under the surface. So sleeping pills mainly aim to target the inadequate sleep of insomnia, sort of like pushing down on the iceberg temporarily. But when all of these underlying factors are present, it can cause the iceberg to re-emerge and resurface over time. Instead, by targeting all of these underlying factors, we're able to gradually reduce the size of the iceberg to treat the insomnia And this is how it leads to long-term improvements over time. So CBTI includes several different treatment components or different advice. This is just one of them, stimulus control therapy. Really good for people that experience difficulties falling asleep at the start of the night. So this is a set of quite simple instructions that should be used and practiced every night for several weeks. So this is not a once-off treatment or one night set and forget sort of treatment. It needs practice, this one, but it's really effective. So what are these instructions? One, to use the bedroom only for sleep and intimacy. So we're reteaching the brain that all of the awake activities are done ideally in a different room and out of bed. Second, to go to bed only when we're feeling sleepy. So our eyes are heavy and we feel like we could fall asleep if we lay down and put our head on the pillow. If we're not feeling sleepy, don't go into bed yet. Number three, if we're not asleep within about 15 minutes, so just a rule of thumb, we don't want people watching the clock. If it's been about 15 minutes and you're not asleep, rather than lie in bed getting frustrated, annoyed, angry, anxious, it's better to get out of bed and go to another room, stay in that other room until we're feeling sleepy again, and then return to bed. So number 4 and 5, to stay in the other room until we're feeling sleepy, and then repeat this process until we're asleep within about 15 minutes. It takes a lot of motivation, and sometimes there's a lot of repetitions of getting in and out of bed, but eventually everyone falls asleep within 15 minutes. What we're doing here is trying to quarantine the bed for sleep and be awake in a different room to retrain our brains and bodies that bed is a place for sleep rather than wake. To get out of bed at the same time each morning, regardless of how we slept the night before, that helps to reset our body clock and start that sleep pressure curve increasing during the day. And finally, to avoid really long daytime naps. So again, brief naps are okay, but we want to avoid longer daytime naps where possible. I realize I'm running out of time a little bit, so we'll go a little bit quicker here. Obstructive sleep apnea, the other most common sleep disorder, occurs in about 20% of the adult population, and we define it as moderate or severe obstructive sleep apnea. More common in males. What is it? It's characterized by a brief narrowing or closure of the upper airway during sleep, despite our body still attempting to breathe. So our chest walls, we can still see respiratory effort. We're trying to breathe, but it's just that the upper airway is blocked. This leads to a reduction in our oxygen levels and increase in our carbon dioxide levels because we're not breathing out as much either. Perceptions of non-restorative sleep or poor quality sleep, and can often lead to daytime sleepiness, fatigue, memory difficulties, concentration difficulties, and so on. Often associated with snoring. It can look slightly different from person to person, so not everyone experiences these daytime impacts, and they can be experienced in different ways from person to person as well. And one of the main ones is choking arousals as well, or waking up feeling like you're gasping for air. This is a bit of a cartoonized version of what it looks like in some polysomnography or sleep study output. So we have brain waves down the bottom here. This person's asleep. Their airflow, breathing in and out naturally until the upper airway closes. This is an obstructive event in the red box. They're still attempting to breathe. So this is movements in those blue bands around the chest and stomach. Their body is still trying to breathe, but the airway is closed. During this time, a reduction in oxygen saturation until the brain realizes that something's going wrong with these blood gases. Often, but not always, there's a cortical arousal or a brain arousal or awakening. Resumption of airflow, opening of the upper airway to start breathing again, and oxygen levels increase again. Historically, the first line or the recommended first treatment that people should receive has been continuous positive airway pressure or the nose and mouth mask. But more recently, the field has moved to a much more tailored or personalized treatment approach where there's different types of therapies that can be recommended or recommended by GPs, sleep physicians, depending on the underlying causes and contributors to each person's obstructive sleep apnea. Finally, restless leg syndrome, another common clinical disorder characterized by unpleasant and uncomfortable urges to move the legs, often worse during inactivity and in the evening, and symptoms are often relieved by moving the legs like walking or stretching, About 3% of adults experience restless leg syndrome. If you think you or a loved one, colleague, friend, so on, might be experiencing symptoms of any of these sleep disorders, your general practitioner is your best initial port of call, who can refer you either for a sleep study, an overnight sleep study, or refer you to a sleep and respiratory physician and do a lot of assessment in general practice. So a lot of what we're trying to do is upskill GPs, psychologists, nurses, and so on to better identify, assess, and manage sleep health and sleep disorders. This is an online primary care guideline that was developed, led by Professor Nick Zwar at Bond University through a Centre of Research Excellence program. The ASA has now taken ownership. Over the next couple of months, we're upgrading this online resource to also include a lot of patient-facing or consumer-facing information, as well as information for primary care clinicians and eventually other groups of clinicians as well. That was a very quick end to the presentation. Sorry if I've gone a little over time there, but I'll stop sharing and happy to have a chat and answer any questions if I can.
Fantastic, Alex. I think we're going to need another hour for questions, so we'll have to be smart in the ones that we select.
Sure.
So much information there and lots of great chat going on in the chat box while you were speaking. Firstly, I'm just going to share a link to a survey, and can I ask that people grab that link and open it up so you can complete our survey at the end of the session. Good idea to click and have it open ready, otherwise you'll lose it. So a couple of technical questions just to start off with, Alex, and then there's lots of kind of as I'm sure you can imagine, lots of very personal individual questions and some that lots of people will be able to resonate with. But a very technical question from Glenn: what are brain waves and what's being measured?
Yeah, electrical activity. I'll open the slide again, actually. So these 4 top channels represent our brainwave activity. There's specific sites on the head that electrodes can be placed to continuously measure electrical activity. C1A2. So this channel here represents an electrode at a specific site in the central lobe, aligned with one behind the ear on the opposite side of the head, and then C4A1, the central lobe, and then the other side of the head. So different specific brain regions or different specific sites on the head that we can place electrodes to continuously measure and monitor electrical activity, and then infer different brainwave patterns out of this. So this is some of the types of brainwaves that we're using to infer when someone's awake versus asleep and what stage of sleep they're in.
Great, thanks, Alex. And then a whole host of questions on sleep length and quality. So I'll bundle them together. How do you determine the optimum amount of sleep? Is there an optimum amount of deep sleep? And can we actually sleep too much? Can that also be a problem as opposed to not sleeping enough?
Yep. So again, variability from person to person. We shouldn't expect our sleep to be exactly the same as our family, friends, and so on. One of the best indicators of our own personal sleep need, sleep duration, is how we're feeling and how we're functioning during the day. So if we're waking up feeling quite tired, exhausted, or if we're really sleeping throughout the day, that can be an indicator that we're not sleeping enough or that we need to sleep slightly more. If we're waking up feeling some residual sleepiness, because it's quite normal to feel a bit sleepy when we wake up first thing in the morning. But if we're waking up and feeling relatively alert and remaining alert through most of the day, or if we might need a single short power nap to get us through the day, that's probably a good indicator that we're getting enough sleep. The difference there, if someone has chronic insomnia, they might not be sleeping too well and be feeling pretty horrible during the day. It's a bit harder just to tell someone with chronic insomnia, okay, get more sleep or spend longer in bed. So that's when something like cognitive behavioral therapy is much, much more helpful, this non-drug treatment to treat the insomnia, reduce the amount of time they're awake in bed, and extend the amount of time they're spending asleep. Does that give a nutshell response to that bundle of questions? It's really
Yeah.
about how we feel and how we function during the day.
Yeah, in the time we have, look, how tight are you in terms of getting off at 1 o'clock? Are we able to go over a couple of minutes if oh
1 o'clock. Yes, your time is okay. I'm free
sorry, I forgot
until 1:30.
you're
Yeah,
in you're in Adelaide, yeah.
yeah.
Yeah. Right. So just to Brett, yes, we'll be sharing a recording of this in a couple of days on the Men's Health Connected website and our YouTube channel, and we'll send out an email at some point. A bundle of questions about screen time, Alex. Someone asked, just have you done research into the impacts of screen time? Others sort of saying, is there a particular length of time between last screen time and sleep you'd recommend? What about these blue light filters that are getting quite common? And also, Kim, when you're doing the sleep routine and getting up, you're not sleeping, you're getting up and doing something else. Is it okay to go and watch TV for a while, or is that something you should avoid just generally?
Yeah, brilliant set of questions. A bit to unpack there. Quite a bit of research in adolescent populations around screen time, different types of content. So whether it's a mobile phone versus laptop versus TV, and the type of content that they're accessing as well, social media versus TVs, movies, or television, whatever. So most of the research in adolescent populations, and I think a bit in adults, main take-home recommendations would be to avoid screen time in bed, and ideally avoid screen time in the bedroom. So if you've got a TV in the bedroom and you're able to, take it out and put it in another room, and try to avoid using your mobile phone altogether in bed. Don't check work emails, don't check social media, and so on. All of that is to consistently teach and reinforce to our brains and bodies that bed is a place for sleep. It's not a place for feeling alert, awake, engaged, or anxious or worried, and so on. So to quarantine the bedroom and being in bed with sleep rather than alertness and so on. So blue light emitted from screens. We know that blue light can have an impact on our body clock. So blue light in the evening generally can start to delay our body clock. Everyone's own body clock is slightly different, and therefore the timing of the blue light and the impact of that blue light on whether it pushes our body clock back or forward and by how much can be slightly different as well. This is why there's blue light filters on phone screens as well now. Generally, holding phone screens really close to our face will generally emit slightly more blue light than watching a television from our couch, and the TV is sort of 3, 4, 5 meters away. In answer to your question about Kim, like what do you do when you get out of bed during stimulus control therapy if you're not able to sleep and you get out of bed? Completely okay to watch TV. Generally, we say do a relaxing activity of some kind. Some sleep psychologists will say avoid blue light and TV altogether because it's stimulating. Other sleep psychologists will say, as long as you're not doing work and giving that time out of bed a purpose, watching TV is okay. The main thing is that you're out of bed during that time awake. And when you are feeling sleepy again, drowsy, when your eyelids are getting heavy, that's a trigger that it's time to get back into bed. Turn the lights off and see if sleep comes within 15 minutes. Yeah, good set of questions though.
Okay, Alex, look, we're going to run out of time with all these questions. So one will have to be to finish off, where can people go to get more information? If you could finish off with that. And if I may, I'll choose a question based on its popularity, the one that got the most thumbs up. So it obviously resonates with a lot of people. And it almost sounds funny, but I think it also, a lot of people can relate to it as well. Why can I find it really easy to fall asleep in front of the TV or on the couch at night time, but then I go to bed and I can't get to sleep?
Yep, sure. Best place for people to go for more information in Australia is the Sleep Health Foundation website. Peak consumer-facing sleep health sleep advocacy organisation, sister organisation to the Australasian Sleep Association. Heaps of evidence-based information on their fact sheets and resources. The second bit, why is it easy to fall asleep like watching TV on the couch before getting into bed? And then when you do get into bed, your eyes spring open and you're immediately wide awake. Really common thing to experience. A couple of possible things going on. One might be a slightly advanced body clock. So we feel slightly sleepier in the earlier evening and might have a tendency to wake up or get out of bed in the earlier morning as well, sort of 4 or 5 a.m. rather than 6, 7 a.m. Another thing at play could be if we fall asleep in the early evening in front of the TV, our sleep pressure has been building up all day, that sharp thin curve. And then when we fall asleep in front of the TV, that's an immediate reduction in our sleep pressure. If we're asleep for half an hour, 45 minutes, an hour in front of the TV, that's quite a long time asleep. And when we wake up from that nap or dozing off in front of the TV, our sleep pressure will be lower than where it would have been. When we get into bed, our sleep pressure is slightly lower, so it might take longer than expected to fall asleep when we do then get into bed. So that's another thing, our sleep pressure. The final thing that might be happening is something called conditioned insomnia, which is the opposite of setting up the bed so it's a trigger and a cue for sleep rather than wake. Conditioned insomnia refers to this exact feeling of getting into bed and the mind springs into action. We start to have racing thoughts, more alertness, sometimes anxiety, worry, and so on. The mind starts racing. So that description is a sign of conditioned insomnia where the brain and body have started to learn this association with the bed is actually a place for being awake and alert rather than a place for sleep. And something like stimulus control therapy can be really handy for reducing those symptoms of conditioned insomnia. That's a very, very quick overview of some of the factors that might be at play, but hopefully gives you a bit of an idea in your response to that one. Yeah.
Really detailed. Thank you, Alex. So, final short question is: a few people have asked if the shares are something which the slides are something which you share or not, or whether.
Yeah, if you've got a mechanism to share them, we can. Yes.
Right. Okay.
So on your website, or yeah, I'll let you work out the
Right.
best way.
So, for those who asked to share, drop us an email with your address to here in the chat box, and we'll liaise with Alex and arrange that. And anything any final thoughts you want to share with us, Alex?
No, just to say thanks again for the invitation to come and talk about sleep health and sleep conditions, and thank you everyone for tuning in for this the presentation on sleep today. I hope the rest of the presentations all go really well.